of the T1 vertebra, which means that from the thoracic spine and downward, the nomenclature actually flips. So the root name is correspondent to the vertebra above it. Okay, so in other words, L1 root will be below the L1 vertebra. L5 root will be below the L5 vertebra. Okay, so as we mentioned in the cervical spine, remember that in the cervical spine, it's up, it's above, so it's above the vertebra. Lumbar, sacral, those are lower in the body, so that's how you remember that it's below the corresponding vertebra. So there are a few more things to say. Here we have, I hope you can see my mouse here. Okay, so we have in the vertebral column, we have the vertebral bodies here. And the vertebral bodies are stacked one on top of the other. And in between we have the discs. And you see how the discs are nicely aligned in this patient, very hard person, very hard to find such pristine kind of alignment. And a few more things to mention is that always try to localize yourself, orient yourself. A good way to orient yourself is to look for the sacral bone. So here we have S1. So if this is S1, above it will be L5, 4, 3, 2, 1. And this will be thoracic, the T12. And this is important because you want to name pathology based on where it is. Or for example, landmarks. So for example, here we see the spinal cord, and you see that the spinal cord ends with this kind of sharp shape. This is the cauda, the conus, which is a cone shape. And then below it, we have the cauda, which is actually lower motor neuron. So this is no longer the spinal cord. And this happens around L1, L2 normally. So you can orient yourself by counting the vertebra. Another aspect here to note is that everything is held in place by ligaments. So we have an anterior spinal ligament that runs anteriorly to the vertebral bodies, but more important for us is the posterior spinal ligament. Now, why am I emphasizing this? Because it is a little bit counterintuitive. We're calling this posterior spinal ligament, even though posterior longitudinal ligament, even though it's actually anterior to the spinal cord. So the word posterior refers to the vertebral body. Okay, so it's posterior to the body. And this is actually a very important ligament here running because it holds everything in place. And in a moment, in 2 seconds, we're going to talk about herniations. Most of the herniations, actually, disc herniations can't go through this very strong ligament, so they go sideways. Unless there's a major trauma that tears the posterior longitudinal ligament, and then we can have central herniations. But most of them will bypass. In degenerative spine disease, they'll bypass, they'll go sideways. Okay? And that's because of the the existence of the posterior longitudinal ligament. Other structures to note here. So in the bottom, we see here, this is probably a lower lumbar spaces because we don't see anymore the spinal cord. We're at the cauda equina. So the horse's tail area, we see the roots here, and they're bathed in the CSF. In this case, this is a CT myelo. We don't typically do those, but it just shows us very nicely the roots. So we see here the CSF. Behind it, we see the ligamentum flavum, which in degenerative spine disease can enlarge. There could be hypertrophy, and it will be part of what causes what you probably heard very common in elderly patients called spinal stenosis. We also have the intervertebral foramina, where You see here all the nerves in the cauda equina. They need to get out somehow. They go out through the intervertebral foramina. And here you see it's quite open, nothing here impinging. So the tunnel here is completely open. So there's no what's called foraminal stenosis. If there would be a disc rupture, I'll show you a picture in a moment, it can cause stenosis of this pathway, and that can cause pain and in severe situations, weakness or neurologic deficits, depending on the nerve. So those are kind of important landmarks. There's a lot more to say about it, but I think for what we are interested, that would be enough. Okay, so disc herniations. This talk is about anatomy and examination. So why are we talking about disc herniations? It's important because it will bring out a very important anatomical point that you'll see in a moment that you will see in life, but also in exam. So there are three types of disc herniations. The most common one will be the one in the middle here. You see the posterolateral, but I would like to mention the other two. So we'll start with the first one, is the midline herniation. We said that's rare. It doesn't typically happen in degenerative spine disease. It requires tear, something wrong with the posterior longitudinal ligament for the disc to rupture in the center. It's very, very dangerous. The disc in that case goes and enters the spinal canal, and it goes directly to the source. It goes directly, not the roots, not anything. It just goes to the either the conus or the cauda. And that's where, those are the cord compression patients after trauma that come in with flaccid paralysis and loss of sphincter control and numbness. And then later on, depending if it's a conus or a cauda equina, they'll develop either upper or lower motor findings. So if it's upper, they may convert from this flaccid paralysis to a spastic paralysis. Regardless, it's a medical emergency, requires immediate attention and recognition. Otherwise, your patient is going to be wheelchair bound and incontinent for the rest of their lives. So you really don't want that to happen. The two more common and less dramatic herniations are the posterolateral and the far lateral. So what am I talking about? So here on the left, we see the more common one, which is the posterolateral. So you see the disc herniation, all this stuff here, the black stuff here, that's the disc herniating. Okay, but you see it's going a little bit sideways, so it's pushed sideways by the ligament here. That's a posterolateral. And then we have the far lateral over here, which goes all the way out. Okay, so you may ask, well, why would I be interested in this? So it's just a matter of semantics, right? If it's posterolateral or far lateral. Turns out it's actually very, very, very important. And why is it important? It's important because it will impinge on a different nerve roots. Okay. Now, if a patient comes in with a neurologic deficit, you always want to make sure that you're able to localize that deficit, because that will be the prerequisite for you to be able to help the patient, right? You don't want to send the patient for disc removal of the wrong disc, right? So, a lot of times a patient comes in with back pain, and without even giving it a second thought, we send them to MRI. And then we see degenerative spine disease and herniated disc. And, not to insult anybody, but you show a surgeon, just like you show a hammer and nail, the surgeon will act, right? But you want to make sure that you're acting on the correct level. And so here is what's important. So what's important to know is that we said earlier that the name of the root corresponds to the vertebra above it. So in this case, here you see the mouse hovering over the L4 root, okay? Because the L4 goes below L4 vertebra. Okay? It goes below the L4 vertebra. Turns out that in order to hit the L4 nerve root, only the far lateral, the ones that are the one that I showed you on the right of the screen earlier, only those will hit that root. Okay. If we have over here in the lower part a posteromedial herniation, then it will actually happen below the exit of the corresponding nerve. So look at a herniation here. The herniation here is between L5 and S1. Here we have a posterolateral, so it's kind of a medial herniation. That's a very common herniation. And you see how it runs below the unaffected corresponding root, which is the L5 root. On the other hand, you do see that it does cause trouble. It does compress a root, but it just compresses the root below. Okay. So what I want you to remember, and we'll practice it in a test exam in a second, is that the posteromedial or posterolateral, the ones that in the middle, in the medial aspect, hit the nerve that goes one segment down. So an L5S1 disc in this medial position, L5S1 will hit the S1 root. And that's opposed to, here we have a disc herniation, which is a far lateral herniation, between L4 and 5. It will hit the L4 root. Okay. All right, so now, so this is just schematically. And here's an example from, I just took a picture from a right exam from a few years ago. Chances are you're gonna see it, because this is a very important concept that they want you to know, and I want you to know, because you're gonna see those patients. So here's a patient that comes into the clinic. They come in, let's say that the patient has back pain, and they have a foot drop, and you wanna know if you want to help them, and if they have foot drop, that means that they have weakness, so they require intervention. So you do an MRI, and you want to see if the findings in the MRI, or if there are multiple findings, which is the one, where is the money? Okay. Now in this case here, we have a herniation over here, which is pretty significant, and then we have a herniation here, which is seems to be less significant. So, but you want the patient to have the minimum surgical intervention possible. So what do you tell the neurosurgeon? So in this case, the patient had a foot drop. So what do you guys think? Is it this one here, or is it this one here? What do you guys think? Open the microphone. Is it, so this is S1. This is L5, L4, okay? Is it the L4, L5 disc, or is it the L5, S1 disc?
The L4, L5.
Correct. Why?
Because, sorry, there's an echo.
Marie?
I think Mimo has to mute Mimo General, because otherwise there's gonna, yeah, he's not.
And so L4, L5, an L4, L5 right paracentral disc herniation would impinge on the right L5 nerve root, and the foot drop is caused, and the root for dorsiflexion is L5.
Absolutely. So here, look at the axial, and you see here, so Murray is absolutely right on the money. Here in the axial, you see the disc herniation here, which is a medial herniation. It's not the far lateral. Okay. So this is what we're seeing here. And this is causing, so if it's, we said S1, L5, L4. So between L4 and L5, so the corresponding root would have been L4, right? But because this is the one, the more medial herniation, the L4 actually left. And this is impinging on the root below, which is the L5. So remember, if you have an L4, L5 disc, and it's the medial type of disc, it will hit the second number, okay? So assuming if we had an axial MRI of this one, it would be also a medial herniation. In this case, L5S1, it would have been an S1 root. So that would be that will have loss of an ankle reflex and a weakness of, in this case, plantar flexion, right? We'll see in a moment. But in this case, this is the culprit. Okay. Is this clear to everybody? This is very important. And as you see, I did it up, it's from a right exam, but you'll see those patients. It's a very common, in this case, you know, it's very clear, but a lot of times you have multi-level degenerative disease, you need to know where the problem is. Okay. Now the lumbosacral plexus, and this picture here is enough to cause, I guess, status epilepticus to a neurologist or non-neurologist. So let's try to unpack all this spaghetti here. So let's break down the lumbosacral plexus to two parts. So the lumbar part, and then we'll talk about the sacral part. And we'll mention one sensory nerve, and then we'll talk about three motor nerves or three actions by the upper part of the lumbar sacral plexus to simplify things. So let's start with a sensory nerve, and this is the lateral femoral cutaneous nerve. This is a very important nerve. You see it running here laterally, and it's a pure sensory nerve that runs under here under the inguinal ligament. It has nothing to do with the femoral nerve. This is the femoral nerve. The only thing that it has in common is the word femoral, but it's a common mistake by, I sometimes even unfortunately hear residents say it. They think that it comes off the femoral nerve. It does not. It's a pure sensory nerve that innervates the lateral aspect of the thigh. And as you know, impingement of this nerve, if someone is obese in pregnancy, or someone spends their days flexed in a flexed position for long periods of time, there's pressure over the nerve here, and we get the syndrome of neuralgia paresthetica. So a pure sensory, it's really, really important to remember that. It's a pure sensory syndrome causing pain, paresthesias of the lateral thigh. When you examine those patients, you'll be able to kind of find this area. But what's very important is to look for weakness, because weakness is not part of this syndrome, which is usually self-limited. You know, if it happens in pregnancy, you encourage the patient, you tell them that later on they'll get better. If it's associated with obesity, you give recommendations about weight loss, or if it's someone who is in flexed position. Actually, probably heard me say this story. I saw someone who likes to cycle a lot, and so they spend their time in this flexed position, kind of a traumatic flexed position, and that was associated with that. It's a self-limiting problem, and it depends on how much it bothers the patient. My patient, I told him that's a problem. I never saw him again, so I guess he just likes cycling and he doesn't want to be told not to cycle. So, which by the way, I didn't tell him. I just told him it's probably related. So that's the first thing that I want to mention about the lumbosacral plexus. So that's a sensory nerve. And now we're going to talk about three motor nerves And there, you remember I told you in this talk, we want to talk about 10 movements, right? 4 movements of the hip, 2 of the knee, and 4 of the ankle. So that's what I owe you. Okay, by the end of the talk, that's what I owe you. So let's knock out 3 movements. In this case, it will be 2 movements of the hip and 1 movement of the knee. Now, why am I grouping them together? And even though they're not they're not involved in one joint, that's exactly what we're saying all the time. The fact that we have joints doesn't mean that the joints are moved by the same nerves. Okay? What is important about knowing about these 3 different nerves here, which we'll talk about them specifically, is that the contribution to those 3 nerves are the same roots. We're talking about nerves that the contribution to them are from the L2, 3, and 4 lumbar roots. And that's extremely important. We love this situation where we have something in common and then something not in common. So in this case, we have common roots, but we'll have separate nerves that are responsible for separate functions that we can examine in the patient. So let's start with the first one. So the first one, well, actually we can do it in this picture. The first one is the nerve to the iliopsoas, this one. So actually let's go back here, this one, right here. There are 2 nerves to the ilios and psoas. Let's group them together. And they're responsible for hip flexion. Okay, so raising the leg upwards from a lying position, that will be hip flexion. And that's the iliopsoas. And that's the roots, the main roots. So the main contribution is 2. It could be 2 and 3, and it could be in some patients 2, 3, and 4. That's the hip flexion. Now notice that this nerve comes off what looks like the femoral nerve, and it does. And in some books, you will see that they say that the nerve to the iliopsoas comes off the femoral nerve, which is fine. Although I think formally, most people will call the femoral nerve once it actually passes through the inguinal ligament, to separate a femoral neuropathy, which we'll see in a second, from these proximal lesions. So in a femoral neuropathy, typically you won't see hip flexion weakness. So that's the first movement to talk about. Oh, sorry. The second nerve over here is the femoral nerve itself. Okay. So going back here we have the famous femoral nerve that goes underneath the inguinal ligament over here. Do you remember the vein artery nerve? So here we have the nerve, the femoral nerve, in the underneath the inguinal ligament, and it breaks into 4, and you know those are the quadriceps muscles. And they're responsible for the extension of the knee. So we're not talking now about the hip. As you know, we're talking about the knee, extension of the knee. And remember, I promised you 2 reflexes. So this is the first reflex. This is the patella reflex, which tests the L2, 3, and 4. Remember, it's all the same nerves, the same roots, 2, 3, and 4, contributing to the femoral nerve. So extension of the knee. Okay, so a femoral neuropathy will cause weakness of extension of the knee. Okay. Now we're going to talk about another nerve, which is responsible. It's the obturator nerve. Here again, there are 2 branches, but it doesn't matter. Just group them as one. As an obturator nerve. Again, L2, 3, and 4. But as you see here, this is the obturator nerve. It's completely separate from the femoral nerve. It's nowhere near the femoral nerve. It's a completely different nerve. The only thing that it shares with the femoral nerve are the roots. And in this case, the obturator nerve is responsible for adduction, adduction of the hip. So we ask the patient to bring their knees together. Okay? This is extremely important to remember. Why? Because this is a very common consult. In fact, this morning, I was presented a patient who had cardiac catheterization and had weakness of the leg. Now, in this case, it turns out that cardiac catheterization happened on the other side of the weakness of the leg. So we're thinking of other locations. Also turns out that he had facial numbness. So it's probably not part of this talk, but it is a common consult that will have patient after cardiac catheterization with weak legs. So it could be like the patient that we had today, that it's probably a central cause, like a stroke. But it could also be because the patient is heavily anticoagulated and they develop a retroperitoneal hematoma. And so it will hit all the lumbosacral plexus. They'll have weakness. Or it could be a local problem where they did the catheterization in the femoral artery very close to the nerve in the groin. So what movement would you test? What do you guys think? Just based on what we learned so far. How would you differentiate a femoral neuropathy, a groin problem, to, let's say, a retroperitoneal hematoma? What movement? What movement should not be involved?
Hip adduction.
Adduction. So you already know enough to separate the two. Okay. So if you have weakness of the hip, of the knee extension, that's expected. If you have a down reduced reflex, that's expected. But that's the only thing that you'd expect from a femoral neuropathy. And in this case, you can do an MRI or ultrasound, and you see a pseudoaneurysm or a hematoma. And it depends on what the problem is. You either need to, if it's a tear, you call vascular surgery and they deal with it. Or if it's a hematoma, a lot of times it just gets better. But the localization is very, very important. Okay. So the hip adduction will help us differentiate. Okay. So enough about the upper part of the lumbosacral trunk. Now we're going to go down to the sacral trunk, but in the middle, to the sacral aspect of the lumbosacral plexus. But in the middle, we have this, the lumbosacral trunk. The lumbosacral trunk is largely, the largest contribution to it, as you see here, is L5. There's a little bit L4 here, but mainly L5. Now, why am I mentioning this? It will become clearer as we go, but I do want to show you here where it runs in the rim of the pelvis over here. This is an area which is very susceptible to pressure. And a very classic cause for pressure on the pelvis, on the floor of the pelvic rim, is a head of a baby waiting to be born. So if you have a large head of a baby and you have a very prolonged delivery, because it's a large head of a baby and maybe it's a first delivery, and so for hours and hours, a baby is knocking their head against mom's pelvic floor, this will squish the lumbosacral trunk, which is a mostly L5 root. Now, where does the lumbosacral trunk go? It goes into, it's a major component of the sciatic nerve later on. But when we have that compression, everything that is L5 may be impaired. So we need to figure out what we'll see in that patient. So put it in the back of your mind as a differential that you have compression of the lumbosacral trunk. Okay, so for now, we're not going to say anything more about it. Just put it in the back of your mind. Okay. Now we come into two very, very, very important branches, even though they're small, very, very important branches, and each one of them corresponds to a movement. Remember in the hip, we talked already about two movements. We talked about hip flexion and adduction, the iliopsoas and the obturator. Now we're going to talk about the two other movements, which are abduction and hip extension. So in order to achieve that, we have two very, very important nerves that share the word gluteal, because the gluteal is important for those movements that we just mentioned. We have the superior gluteal nerve and the inferior gluteal nerve, and the difference between them is that the superior is just above the inferior. And what it means if it's above is that the contribution to it is from higher up roots. So the superior gluteal nerve here, as you see, the contribution comes from L4, L5. Remember the lumbosacral trunk over here? L5 and S1. Okay, so the superior gluteal nerve, L4, L5, mainly L5, and S1. And then we have the inferior gluteal nerve, which is lower, one segment lower. So L5, remember lumbosacral trunk, again, major actor. So L5, S1, and S2. Okay, so one segment lower. Now, what does each one do? So the superior gluteal nerve here, innervates the muscles that do abduction. So we have the gluteus medius and minimus and the tensor fasciae lata, and they're the ones who abduct, take away our hip outwards. Superior gluteal. And then we have over here the inferior gluteal nerve. It's kind of a denigrating name because it innervates the largest and strongest muscle in our body, the gluteus maximus. So this will make it easier for you to remember. The inferior gluteal nerve innervates the gluteus maximus, the most powerful muscle in our body. And that's what extends our hip. And that's what allows us to rise from a sitting position. Okay. So remember that. You know, it's a little bit counterintuitive. The inferior gluteal nerve innervates the gluteus maximus. Okay. So by that, we finished the four movements of the hip. So we talked about the flexion, adduction, and then we talked about the lower part of the lumbosacral plexus. So different location, different root. So the other two movements that we talked about are L2, 3, a little bit 4. And here we're talking about two movements of the same joint, which are L4, 5, and S1, or L5, S1, and S2. So much lower location, but still the same joint. And we're talking about the abduction and the flexion, sorry, the extension of the hip. So, and remember that the lumbosacral trunk contributes to both. Okay, so let's go on with our Odyssey. And here we see that, actually, let's go back. You see that we have here all these roots come together, and all the lower roots come together, and they become this massive, massive nerve, actually the largest nerve in our body, which is the sciatic nerve, which actually you can dissect it and see that it's composed of two parts, a part which is the tibial part and another part which is the common peroneal. we'll see later on that they actually they don't get along very much together and they separate. But at the thigh, they're still a married couple. And they're responsible for another movement of the 10 movements that we're discussing. And that is that's the antagonistic. So it's the knee flexion, which is the antagonistic muscles of the quadriceps. So we talked about the quadriceps earlier that extend the knee, and they are also responsible for the patellar reflex. So here we're talking about the hamstring muscles. They're in the backside of the thigh, and they're antagonistic of the quadriceps, and they are supplied. So it's a semitendinosus and a membranosus. The short and long heads of the biceps. Those are branches that, nerve branches that come off directly off the sciatic nerve. So even though the sciatic nerve is such a large nerve in our body, it's the largest nerve in our body, in terms of direct contribution, it's just that movement. It's just the knee flexion. Okay? So those are the hamstring muscles. So if you think about it, and that's you know, those are the around mainly L5S1 contribution. Again, lumbosacral trunk. So if you think about it, we're done with 4 movements of the hip and 2 movements of the knee. Right? We're doing good. Now we're going to mention the terminal branches, which is essentially the split of the sciatic. And this is what happens. Behind, so the sciatic is a posterior compartment nerve, and when it reaches behind the knee and the popliteal fossa, that's when the 2 components decide they can no longer live together and they separate. And they separate to the original nerves that consisted the sciatic. As I told you, if you look in the microscope, you can actually dissect them, but they're together. And they split into 2. There's one component that continues in the back in the posterior compartment of the leg, which is the tibial nerve, which was responsible for the innervation of all the muscles in the posterior compartment. And the other component is the common peroneal nerve, which will in a moment flip the patient over. You'll see that it actually goes anteriorly and is responsible for the innervation of the lateral and anterior compartments of the leg. Okay. So let's start with the tibial nerve. The tibial nerve, as we said, is responsible for the posterior compartment of the leg. So those are the calf muscles. And the strongest and the famous ones that you know are the gastroc and the soleus. And they're responsible for the first movement that we'll mention of the ankle joint. So if this is the ankle, so this is the leg, and this is the foot, okay? Imagine my hand is my foot, otherwise I'll have to flip my legs over and I'll fall backwards. So in this case, we're talking about the gastroc and the soleus action innervated by the tibial nerve, and that's the action is plantar flexion. We're planting the foot in the ground, plantar flexion. So that's a little bit of L5, but mainly S1, and that's also responsible for the ankle jerk. So the ankle jerk, the Achilles tendon jerk, activates the gastroc and the soleus, and it tests the S1 root through the tibial nerve, through the sciatic, okay, through the lumbosacral trunk. Part of it, a lot of it is the actually S1 contribution to the sciatic nerve. Okay, so that's the first movement. Now I owe you 3 more movements of the ankle. And the next movement, if there is a movement that, you know, there's a hierarchy of importance, open your ears. This is a very important one. And this is the tibialis posterior. The tibialis posterior is a branch off the tibial nerve. It is also an almost purely L5 root contributed nerve. And it's responsible for a kind of a complicated movement to ask patients to do, and that is inversion of the foot. Okay, so I hope you can see my foot here. Inversion. The inward movement of the foot. Extremely, extremely important because of the fact that it's an almost purely, it depends on different patients, but it's an almost purely L5 contributed nerve. Okay? And the importance of it, you'll see in a moment. Okay? I'm sure a lot of you already know, but it's really important. So put it in your hard drive, you know, etch it in stone in your hard drive. Tibialis posterior, inversion of the ankle, L5. Okay, so we talked about two movements of the ankle. One of them also shared a reflex, L5S1, but then we have the inversion, which is almost purely L5. So that's the tibial nerve. Now the common peroneal, which is the other component of the tibial, of the sciatic nerve. And here you see how it meanders down, and we're flipping the patient over. So in this case, so here we're looking at the patient from the back. Okay. And now we're flipping the patient and we're looking at the patient from the front. Okay, I hope it's clear to everybody. We flip the patient and we see the fibular, where's my mouse? Okay, here's the mouse. We see the fibular head here, and we see the common peroneal wrap around anteriorly under the fibular head. This is a really dangerous spot for it. You can actually tap it and you'll have kind of this funny feeling like hitting the funny bone. That's where your common peroneal nerve runs. And by the way, annoyingly, the official name is actually not the common peroneal, it's the fibular nerve. So you'll see in books that there's another name for it. It's the same nerve, fibular nerve. No one uses that terminology. Only annoying, nerdy neuromuscular attendings. But so I guess I should be using that term. Okay. Anyway, it's common peroneal, but you'll see in books fibular nerve. But we'll not use that terminology. We'll only use the peroneal terminology. So the common peroneal, the reason it's called common is because it actually has two components that split. And they split right here below the fibular head. One goes laterally, and that's the superficial peroneal nerve over here. And it's responsible for the outer rotation of the ankle, the peronei muscles. Okay? So we have the peroneus longus, brevis, and tertius. There's also a sensory component. So the most of the bottom of the foot is sensory innervated by this superficial peroneal. It's very important for us EMGers. What I should have said earlier, that the common peroneal is mainly an L5. It's derived mainly from L5 root fibers. It may have some L4 contribution in some patients, but it's generally an L5 root derived nerve. So we have here, we have the superficial peroneal, which is important for the outer movement. And then we have the deep peroneal here. Where's my mouse? Here it is, which is responsible for the anterior compartment muscles. And that's the last movement that you need to know, that it's the dorsiflexion of the ankle joint. So here the most important muscle is the tibialis anterior, but we have other muscles. One of them that we check in the EMG lab is the EDB, the extensor digitorum brevis. But those are all innervated by the deep peroneal nerve, L5 root. So contributed nerve. So by that, we finished all the movements of what we need in order to test the patient. So let's put it into a test, and this will be a patient that you'd be called a million times. And this would be a patient after a very long delivery, and the complaint will be that the patient has a drop foot. Okay, so they have weakness of the dorsiflexion. Now the question is it a problem over here because of the position that the patient is in the stirrups with the legs bound? So we also see it in patients after prolonged prostate, they have cancer or something like that, in that position in males, or in long delivery in women. The legs are spread in stirrups, and there's pressure on the outside on the common peroneal nerve. Then they may develop, after prolonged time, a drop foot. It can also happen to people who lose weight or people who cross their legs very often. They may have weakness of the dorsiflexion. But the question is it really this very common? This is actually very common that we see. Is it just this, which is a lot of times pretty benign, and we'll go, if it's just pressure, if it's the, in the post delivery, we tell them that, it's going to last a few days, but it should get better. And if it persists after 3 weeks, we should do an EMG and find out if it's more than that, if we missed anything. But typically it gets better. There's a pretty benign problem. But the question is it just that? So what we need to do is we need to go upward, do the whole odyssey, and see if there are other nerves involved that are not the common peroneal. Okay. For example, is it a L5 root problem? Or is it a lumbosacral trunk problem? Remember, head of baby compressing lumbosacral, L5? Is it a sciatica? Remember, when we use the word sciatica, most people actually use it wrongly. They say sciatica and they actually mean radiculopathy. But there is a true sciatica. There is a true sciatic neuropathy. At least some people believe so. The sciatic nerve goes under the piriformis muscle, and it could compress it. And actually, there are people who believe that you can sever the nerve and sever the muscle and take care of the sciatic. Regardless, the nerves that eventually reach the tibialis anterior can be impaired in sciatica, and that can cause this weakness. So which one of those? Or could it be that the patient had a bleed in her retroperitoneum, and that's causing the foot drop? Or is it a disc herniation that now has become worse, impinging on the L5 root? So the way to approach it is to go to look for involvement of other nerves and see if that helps us. Any involvement of another nerve will tell us that it cannot be just a common peroneal. So if it's just this movement, and by the way, dorsiflexion will go almost always with this external rotation, the E version of the foot. So the E version, it's hard for the patient to understand what to do, but it's also not very useful. But any other movement that would be impaired would tell us that it cannot be just a common peroneal neuropathy. So we'll test, for example, components of the tibial nerve. Okay. So plantar flexion. Or remember our question, could it be a radiculopathy? Could it be an L5 radiculopathy? one of the most important nerves that would distinguish an L5 radiculopathy. If a patient comes in, this is quite common, an L5 radiculopathy, they will have a pure L5 deficit, and those patients will have this combination of weakness of the dorsiflexion and eversion. Again, you cannot have a problem with eversion if you only have a common peroneal neuropathy. And the same goes up. If we have a weakness of the hamstrings, cannot be a common peroneal. It must be something higher up. Again, suggestive, for example, if it's a prolonged delivery, lumbosacral trunk. We also are not expecting the patient to have weakness in her hip extension and hip abduction. Okay, because these are higher up. These are not common peroneal. Again, suggesting that it's something higher up. Again, suggesting that it could be a lumbosacral trunk.
Hey, Dr. Perk, I just wanted to clarify something because either you misspoke, I misheard, or my understanding is wrong. You said that a problem with foot eversion cannot be from the common peroneal. It's not inversion that's impaired with common peroneal.
I misspoke. The inward movement, the inversion. Thank you, Matt. The inward movement, inversion, is tibialis posterior, and it's not common peroneal. Now I realize that I said I misspoke. You're right. Matt caught me, and I hope I didn't confuse you. So the movement, the inward movement, is tibialis posterior. It cannot be a common peroneal. So pressure on the fibular head from stirrups cannot explain inversion, weakness of the foot, okay? So everything, if we have the involvement of all the muscles that I mentioned, then you need to think of something higher up. In this case, it could be a lumbosacral trunk problem. Or if the patient has back pain, you start thinking of a radiculopathy. Radiculopathy invariably has back pain. I just want to finish up with one thing that will, just again from right exams and just to show you what we do in the clinic, and that will be, even though that I told you all this stuff about these consoles, a very common presentation to the EMG lab would be actually a question of common peroneal neuropathy. And what we do is we actually test the nerves in the leg, and this is okay. This is what we do. We have recording electrodes here in the extensor digitorum brevis. Okay, we said it's innervated by the deep peroneal nerve here, and we stimulate the nerve along its pathway. So we stimulate it here distally. We stimulate it a little bit more proximally, but underneath the fibular head. And then we stimulate it here behind the knee, above the fibular head. Okay. Now the rule is no matter where we stimulate, we expect the amplitude, the shape of the response, the CMAP, to be very similar. It's an all or none thing. We're activating the nerve. It doesn't matter where we're activating. Right? The only thing that would be different is the time from the stimulation to the response. So this stimulation here, the distal stimulation, would be very close to the response. So the response, we expect it to be very close to the beginning of the trace. When we stimulate here, this will take a longer period of time. It will take probably 40 meters per second. So it'll take a few milliseconds for it to reach. So we'll see the same hump, the same CMAP, but it's just going to be a little bit delayed. And the same goes for this stimulation here. We expect it to be the same size, the same shape, just a little bit delayed because it takes a little bit longer from here to here. We actually measure with a measuring tape, and we calculate the velocity. So here how it looks like, and this is again from a right exam. I took a picture just so you believe me that it's important. So not maybe if you think not for the patients, but at least for you for the right exam and boards. So question number 238. So here we go. we have here the 3 stimulations, the distal one in the ankle. So there's, okay, so we'll call it A1, A2, A3, okay? A1, A2, and A3. A1, A2, and A3. So we see the first C map here, very nice, as we expect, close to the stimulation. Stimulation time point is here. Very nice C map. And then we do below the fibular head, we get the same response, more or less, just a little bit delayed. And then we see here what happened here, per definition. Or SIC. What happened here, per definition?
Low amplitude.
Low amplitude. And if it's below 50%, we say that there could be a conduction block. Right? And so if you look back, we stimulated here, we got this nice C map. We stimulated here, we got nice C map. We stimulated here, we got a significant drop. Now we know the nerve is functional, you know, because it, you know, the nerve is functioning, it's innervating the muscle here. But here we have a drop, and the drop is between here and here. So this is a very common compression site, exactly what we would expect if someone had prolonged pressure over here, over the peroneal nerve. So that would be a peroneal neuropathy. So this is how it will look like in the lab. Any questions? All right. Go get them.
Thank you.